and you have another doctor charging you 2,000. There must be a standard. There is a standard among lawyers. There is a standard among engineers. There is a standard fee that architects can charge you. We must have, and I am sure I can see Professor Golicha looking at me, but sometimes we have to say it the way it is. We have to say it because we are defending the Kenyan patient. Honorable Speaker, just to highlight, because it's a matter before court, the importance of the U.S. government-Kenya health collaboration. This partnership provides over $300 million annually in support of our HIV, malaria, and TB programs. As we move towards the sunset of some of this international support, and I want to thank this House, Kenya was the only country that was allowed to come and sign in State Department. We were the first country to sign globally. And we were the first country that were allowed to sign in Washington, D.C. And that's how important Kenya is a leader in the healthcare. And many countries want to learn the universal health coverage and share from us. And most of it is because of the lost 120 county facilities, 0.1 billion, which the government has not paid for. It's fee for service. You go to a hospital, go through a CT scan. That CT scan, SHA pay part to the hospital and part it will pay. You will find a private wing. Today, the number of referrals, very few Kenyans are referred to Kenyatta Hospital or Kenyatta University or MTRH or Jaramogi, because all our county hospitals now, majority of them have the latest equipment, dialysis machines, CT scans, mammograph. You'll find them in all our, reducing the burden. Kenyans used to die on the road. So when we talk about healthcare transformation with the support of our members, UHC is about ensuring that the quality of care received by a president is the same quality of care available to a peasant. To achieve this, we have entered into a strategic collaboration that are already bearing fruit. And I really want to ask my sisters who are in this room to listen to me. When I became the minister, that drug now is sold at 40,000. And that's why SHA is paying for the full treatment for our sisters and mothers who battle breast cancer. That drug cost was very prohibitive, and it was forcing families to hold fundraising or forgo treatment. Now, under SHA, it's accessible at zero additional cost to the patient. We have also formalized our collaboration with Aga Khan University. I did a partnership with Aga Khan to allow SHA beneficiaries to access the specialized service like kidney transplant. You know what happened in Eldoret? And Honorable Speaker, I really want to indulge you today. An audit was done on what Medihill did in Eldoret. The way kidneys were harvested, the way foreigners were brought in. Our country. A good report was done. Illegally young people, without regard to safety and ethics that comes with it. So today a Kenyan of any status can walk to Aga Khan as long as he has a donor. Kidney transplant will be done at the cost of SHA, 1.2 million shilling paid for. Pre and post. Aga Khan used to be a hospital of the rich. Today, if you go there under SHA, at the dialysis center, you'll find in Nairobi Hospital, Nairobi West, in Kenyatta, you'll find all that. There are many people who say SHA is not working. If it's not working, then how come 29 million people have registered? There are some of the people who are saying it's not working. They are very sad because their county is number 2 or number 3 in SHA registration. For example, Nyeri is number 3. Number 1 is Mombasa. Let's clap for Mombasa. Number 2 is Bomet. Number 3 is Nyeri. Number 4 is Kirinyaga. I can continue. But for our colleagues, like me, who come from the Asal, if I start naming the bottom, that is where we are, including my own county. And I have to say it. But we must clap for the counties. Elgeyo Marakwet, Kericho, among the top. Lamu, among the top. As small as it is. Honorable Speaker, we have also have an agreement with Nairobi Hospital, a historic collaboration for kidney transplant at SHA rate. Honorable Speaker, these collaborations translate to one simple reality. We are demonizing the walls between the rich man's hospital and the poor man's hospital. Under SHA, every Kenyan has a seat at the table of quality health care. Honorable Speaker, I now want to speak to key moral imperative. And I want our sisters to listen to me. And this is the health of our mothers and children. Every woman, every newborn, everywhere, agenda. And our rapid result initiative that we carried as a ministry last month showed that 26 of our counties have drastically reduced their maternal mortality rate and newborn child death. But we have 25 counties which are in the red. We are trying to make sure that those 25 counties, we have an engagement with them at the level of the presidency and the council of governors, and no mother, Honorable Speaker, no mother should die while bringing. We are not doing very well. We're losing a lot of mothers in our facilities. And I want us to clap for the people of Central Kenya. Central Kenya. For them. The maternal mortality and new child born rates are very minimal. Those of us who come from Eastern, Western, Pastoralist, Nyanza, Coast, we have some work to do. And I am ready to lead from the front. I'll work with the leaders. That we are losing more mothers in those regions than any other part. Honorable Speaker, let me talk about the Kenyatta National Hospital, one of our world-class milestone. When I founded Kenyatta, and I'm happy to report today, the chairman of the Kenyatta National Hospital, the former Secretary General of Kenya Red Cross, through his corporate network, today we are refurbishing 9 wards in Kenyatta at a cost of 270 million, paid for by the corporates, banks. He went to Equity, he went to KCB, he went to many other organizations, and today they are refurbishing at a cost. Today, Kenyatta National Hospital has established the state-of-the-art HLA lab for organ transplant matching, ending our reliance on expensive foreign laboratories. We are not sending now tests to South Africa or to the CDC Atlanta. Kenyatta National Hospital is doing a lot to our community. Record-breaking surgeries you watch in the news every day. Beyond our borders, we want to position Kenya as a leader in global health security. And we have formed the Kenya National Public Health Institute. We have expanded our laboratories and our emergency operation centers. We want to build a resilient system that can detect and respond to pandemics long before they reach our doorsteps. However, Honorable Speaker, these gains remain fragile without a very strong intergovernmental synergy. And I want to urge the National Assembly to ensure that health remains a whole of government priority. Health security is inseparable from the work of the Ministry of Interior, ICT, Education, National Treasury, and many others. Honorable Speaker, let me come now to the legislative agenda as I conclude. We laid the foundation and we have secured the standard of care. And I wish to bring to your attention that there is a bill before the House called the Quality of Health Care and Patient Safety Bill 2025. This bill is critical bill is already before the House. It went through first reading on the 14th of August 2025 and has been committed to our Departmental Committee on Health. This bill will guarantee the safety for every Kenyan patient. It establishes legal framework to ensure that the care paid for by SHA is care that cures, not care that harms. And I want to give an example. When there are 2 mothers, pregnant mothers sharing a bed, that is not care. Do we agree? When we have a mother or a patient, even male, on the floor of a hospital, that is not care. Particularly in a cold place like Nyandarua. Do you know, have you asked yourself why there are no more Kenyans sharing beds? Do you know what we have done in the system? Every hospital, in their license, they have their bed capacity. So if your hospital has 50, we will not allow you to admit more than 50. 2, in the old NHIF, the 2 mothers who are sharing the bed and the one on the floor, both the 3 of them were paid by NHIF. So they were making money. Now we have said, and we watch the bed occupancy. If I had the Digital Health Agency CEO, we could have shown you You know a good example, Kenyatta Hospital. Kenyatta Hospital ideally is supposed to have a bed occupancy of 1,800. But Kenyatta was admitting 2,200, extra 400. Today, if you go to Kenyatta, you will not find two mothers sharing a bed. But what I am doing is the system and administrative. I really want you to do that in legislation. We define care in that bill. A care of a patient, the dignity of the patient, the safety of the patient, the ethical standards of the patient are all defined in that bill. I really want to ask Honorable Speaker and members and our committee to fast track that bill in the first quarter of this year. It will really help us help our patients. Then we have a number of other bills that are in Parliament. The Health Act Amendment, the Public Health Act, the Tobacco Control Act, the Cancer Prevention and Control Act, the Food, Drugs and Chemical Substance Act, the Pharmacy. All these are amendments. They will really help us if they are fast-tracked. Honorable Speaker, finally, to sustain this momentum, we require your budgetary support. To clear the pending claims and ensure that seamless operations of free primary health care, we urgently require, we have already told the National Treasury, they have committed to us, but the Leader of Majority and the Chair of Budget can help us, them to release the 5.9 exchequer release so that we can pay facilities for the month of October, November, and December in the primary health care, in the dispensaries, and in the health centers. But they have said they will pay before the end of this week. We also wanted the projection deficit of the PHC, and the Chair of Budget is aware, is about 11.9 billion, and we want it to be factored in. Between now and June, we want it to be factored in the supplementary budget. When we were looking at the maternity package, we realized the people who design SHA and UHC, they have left a very component. There are places where our mothers deliver in health centers. They deliver even in dispensaries. And sub-county or level 4 hospitals are very far from them. And after that discussion, and we did a paper, the summit chaired by the President, the Council of Governors, we have agreed now our mothers, because we want to reduce the maternal mortality, maternal and child mortality rates, we have asked now to be given more resources of 2 billion so that our mothers can now deliver in health centers and in some dispensaries in some of our constituencies. Honorable Speaker, and this is just to save our mothers and our newborns. Honorable Speaker, I have come with the very senior members of my ministry. If you allow me, PS Oluga is busy chairing. I left him in Nairobi to chair another workshop. I have PS Mary Mudhoni of Public Health and Professional Standards. I have the first Director General under the new Constitution of Health, Dr. Amoth, Dr. Masi Mwangangi, CEO, SHA. One of my directors from KEMSA, Operations, and then Terry Rotich, who's the head of legal in SHA. I think those are the ones. Yeah, I have another team, the gentleman at the far end, the two gentlemen are two directors with Social Health Authority. Honorable Speaker, just to conclude, the state of our health care in our country is transforming. We have moved from a deficit-ridden NHIF to a more surplus-generating SHA. We have moved from a paper files to digital superhighway. We have moved from volunteers to paid community health promoters. This transition is unprecedented. It is working. It's what President Ruto and his administration have promised, and I request your continued support as we anchor these gains in law and practice. Thank you very much, Honorable Speaker. and members, God bless you, and I'm ready to answer. Just to, in case members have issues with the headline of today, on the headline, the 11 billion are the rejections I've told you. Those are money lost in the sense that they have claimed, we have found them, they are remitting, some of them are going to court, some of them have agreed to return back our money, and we have not finished. We have, I don't want to, you know, there are some things that belong to the criminal justice system. I don't want to speak for. I have the whole list. The biggest junk is the private hospitals, followed by the county hospitals, followed by the National Referral Hospital, including Kenyatta, MTRH. The lowest is with the faith-based hospitals. We have the names we can publish. There are rejections. They claimed for services they have not offered. And they have done all that I was telling you. And I am sure that many people, including those who are criticizing me, some of them, this morning they sent me a text message and they said those people must be prosecuted and they must return the money. You cannot eat the money that belongs to a patient in Kenya. Thank you, Honorable Speaker.
Thank you. Thank you, Waziri. Honorable members, you've heard the minister is with his team, Rachel. We're doing 10-10. Yes, yeah? Oh, Dr. Nyikal first. Lower your hands. We promise to give Dr. Nyikal 3 minutes.
Nyikal, just 1 minute. Honorable members, for those who walked in and out, let us first of all give a round of applause to the Honorable Duale. Indeed, Honorable Speaker, the Honorable Duale has done very well. In terms of making a presentation, we can tell when a presentation is good. And we are so proud that he is from this house. And it makes a difference when someone who has the experience that is required gives such a presentation. We appreciate. He has taken us through the journey that the transformation. He has given us the role, the pivotal role of Parliament in legislation and way forward and what assistance that he needs. He has given us a comparison of what happened in NHIF and what is happening in SHA, including the numbers, including registration, the depth, including the amount of money that is being paid in and out, the role of national government and the counties in health, and the complications therein and what support that he needs. Honorable Speaker, he has also given us assurance that it is not about your economic power that will make a decision on your access to health. These are the kind of presentations, Honorable Speaker, that we want. Mr. Speaker, he has given us this House assurance that we are not going to export our patients and also export our money. The measures he has put in place, we like that. Thank you. And now I'm going to give a chance to Dr. Nyikal. Welcome, Dr. Nyikal.
Okay. Mr. Speaker, let me first of all appreciate the Cabinet Secretary for the presentation. I'll not say much because this today is the presentation of the Cabinet Secretary to the House. So the members will deal with that. Most of the issues he has raised, we have actually discussed with him in the committee. We have had interactions, some of which you have seen on TV, and these are the results. They just I'll just make very few comments. One, there are some issues he has raised that we'll still have to look up with them as a committee. So I don't expect to say much on them. We'll have opportunity as a committee to call the team and have that. But the only ones I want to say that are really important is the issue of registration and payment of premium, which is a gap of 29 million and 4 million. It has issues. The issue of county and national government coordination, and that is what affecting KEMSA not getting drugs there because drugs are being bought at the county and they are not paying KEMSA. So that is something we will discuss with them. The issue of primary care fund, which we actually gave this time, and that has to be used at the county level, in level 2 and level 3, where he actually we agreed as a committee that women do deliver there, they should be paid. So we look at that. Then the issue of human resource transition, the one of NHIF to SHA, is again something we'll sit down and look at. The issue of UHC staff and interns and global fund, I must congratulate the budget committee, Chair Atandi. As a committee, we managed to put some money there, and for the primary care, we are also going to put money so that women can deliver in level 2 and 3. And the other issue of the bills, those ones we are actually taking on. We have those bills, some we're already looking at. But the biggest one I want to talk about is the benefit package and the cost of care. We have a benefit package in the country, but we don't have a cost of care. So how can you have a package if you do not know its cost? So I know they're working on that. They have put up a team. We'll work with them to have the cost of care so that one surgery has a cost wherever you go. And I think when we do that, we should be able to get more done. It is its day today, and members of the assembly, so I'll leave it there, because we'll also be taking some notes on what the members say that needs to be done, that we can follow up with him. Thank you, members.
Rachel, take the first 10.
The Honorable Shabir, the Honorable Mother Wangari, number 2, the Honorable Elemengit, can I just do this side? Okay. The Honorable Makalimulu, the Honorable Member for Kinangop. We wanted 10 here, 10 here, 10. Is that okay? The Honorable Member for Kitui Rural, and that one is the nominated member UDA. How many are those? I started with Shakil. I went to Wangari. I went to Makalimulu. I went to the member for Kinangop. I went to the member for Kitui Rural. I went to Mudhoni and Charles CNN. How many are those? We can get another 3 here. We can start with the nominated member. Can we go to this member? Odipo. And the 10th one, the member for Nairobi. 10, Honorable Speaker. So when we start again, we'll come this way and then that way.
Okay, number 1.
Thank you, Honorable Speaker, sir. Bwanandwale Waziri, we have known each other to 2007, and I've had a great faith in what you do, and what you said today, you have convinced me. Mr. Speaker, I want to stand testament today. I put nearly 10 million in NHIF last year. That was lost, but my constant, and Waziri, thank you, and Mercy, thank you. We went and recouped 2.4 million. And that money, sir, is now giving 2,300 applicants, indigents, for 2 months, SHA. Next week, I promised her I'm coming with 6 million. Now, Mr. Chair, Bwana Speaker, I don't have to say this, but I am been diagnosed with a little bit of cancer. So when I went to do my PET scan, I gave my insurance card. They said, no, SHA will pay. I said, they will never pay. SHA paid. The other day, I went to take some medicine, 100,000. I went to take some medicine from Nairobi Hospital. I gave my insurance card. They came back and gave it to me and said, SHA has paid. So today, Bonandwale, whatever others say, for me, it is working. Asante sana.
Number 2.
Thank you. Thank you, Mr. Speaker. And Waziri, Mr. Speaker, unlike what we had in the morning, at least this CS had prepared, had done some homework for his presentation to the honorable members of parliament. Mr. Speaker, I am also very glad that the trust deficit in SHA has substantially reduced. But my question, so that I save time, Mr. Speaker, is the issue of incentivized surgeries. The reason Waziri unasema mambo ya CSS in a hospital is because CSS are paid better and so many more times than normal deliveries. Mr. Speaker, we may not deal with the money, but what this is doing to the women of this country. You go pregnant, you're due to give birth. You're told your child is in distress and your cervix is not opening. They don't even try to induce. You are taken to theater and you're cut open. So, because they are paid better. So, Waziri, how do we disincentivize the issue of surgeries? Because we cannot keep doing this to the population of this country. We are opening up women who can easily give birth normally without going to the theater.
Thank you.
Finally, Mr. Speaker, allow me, because I've not asked any question in this plenary, allow me finally. The issue of doctors and complaints. KMPDU covers their doctors. I have, in the last 3 months, dealt with mothers who have removed fibroids but have been left cotton wool. I don't know what has been left in their stomachs, Mr. Speaker. And lodging a complaint is actually impossible because the KMPD will cover their own. How do we deal with the code of conduct and the criminal negligence of doctors at that level, Mr. Speaker? Because Kenyans are dying and they have nowhere to go for redress. Issue of alcoholism, how do you deal with that in our doctors, Mr. Speaker? Because there is a problem. I would want to hear your response. Thank you very much.
Lele Mengit.
Thank you, Honorable Speaker. First, I want to appreciate Waziri Duale for his perfect presentation. I also want to appreciate what SHA has done. Recently, Honorable Speaker, about a week ago, there is a mzee who is about 96 years old. He had been blind for the last 4 years. And when I visited him, I assessed the situation and he accepted to go for an eye checkup. And it was just a simple issue of eye cataract. And it was removed. The mzee is now seeing. He's been blind for 4 years, and it was fully paid by SHA. Now, my question is, Honorable CS, while we appreciate the government for paying for kidney dialysis, we know patients suffering from kidney issues are close to 10 to 15% in this country. While we appreciate that SHA is paying up to maximum of 11,000 shillings per session across the country, we still have a challenge in settling claims. We have small startups, local companies in this country or hospitals whose claims have not been paid for almost the last 3 months. For example, Oaktree Center, Kidney Center in Eldoret, Honorable CS, what are you doing so that you can prioritize these startups who are dealing with these issues so that their businesses cannot close down? Thank you, Honorable Speaker. Thank you.
Makale Mulu.
Yeah, thank you so much, Honorable Speaker. I want to join my colleagues in appreciating the presentation, Honorable Speaker. Honorable Speaker, one of the highlights of the presentation which I picked is the issue of consultants charging different rates. And I think to me that is very important that that figure is harmonized. But my question, Honorable Speaker, is on the distribution of medical equipment. I would want to hear from the CS what criteria has been used to distribute this medical equipment, Honorable Speaker. Because, Honorable Speaker, my own county where I come from, we realize that very basic things cannot be done because that equipment is not there. So is it based on needs assessment or how is it done? Thank you, Honorable Speaker.
Thank you. Kinango, is that Kwenya?
Yes, Mr. Speaker.
Kwenya?
Yeah, thank you, Speaker, for the opportunity, and I join my colleagues in applauding the Minister for his beautiful presentation. But on it, Mr. Speaker, I want to know what the Ministry is doing, and actually it has been mentioned, but not in depth, in terms of harmonization of charges, especially that are being charged by the private hospitals. You realize service like dialysis is being charged at about 11,000 in public hospitals, and that is what SHA is paying for. But private hospitals are charging to the tune of close to 200,000, and I have evidence to that case because my dad is doing dialysis at the moment. What is the Ministry doing to make sure that those exorbitant charges by private hospitals is dealt with and with finality? Thank you.
Kitui Rural.
Thank you, Mr. Speaker, and thank you, Honorable Duale, my friend. I always have a lot of confidence in you. When you are presenting, you talked about the 11 billion, how you are trying to recover that money. But I wanted to hear more on what systems are you putting in place so that this kind of debt is not going to occur again. Because this is money which is supposed to be used to buy drugs and other facilities in the health centers. Thank you very much.
Next, Mudhoni Marubu. Is it Mudhoni? No, Mudhoni nominated. Ikiara.
Thank you very much, Honorable Speaker. Honorable Speaker, I too join my colleagues to thank the CS for coming when he is very well prepared for this session. We laud him for that. Honorable Speaker, my question is, what measures, Wasiri, as your ministry put in place to protect Kenyans from counterfeit medicine? More so, especially those who have chronic illnesses like diabetes, blood pressure. Honorable Speaker, I'm asking this in reference because I am a victim. When I go buying my medicine from the pharmacy, at times I have encountered a case where I bought counterfeit medicine, which when I take it does not work at all. What is the ministry doing to protect Kenyans who are not aware like me so that they don't take counterfeit medicine, which is not working? Thank you.
Nguna.
Thank you, CS, for awesome presentation. We are fully satisfied with what you've done so far. And again, congratulations. Since you took over SHA, it is now working. I have witnessed because I've had several patients there. Congratulations for that. My question is, how many health facilities involved in the fake claims have you shut down so far?
Kipchumba.
Thank you, Honorable Speaker. I want to first of all declare that I am a health advocate. I've worked with the Ministry of Health in the Vaccine Preventable Diseases campaign. I've been awarded the UN Person of the Year in 2015, fighting and kicking polio out of Kenya and Africa. It has been great. SHA, like the previous program, NHIF, and other health insurances, very little is given to therapies. There's limited package to support long-term conditions. And this in particular, children that have disorders of cerebral palsy, spina bifida, hydrocephalus, and other conditions, and it's lifelong. What is SHA doing to include the essential drugs, medication, in supporting these children, because, or persons, they have to live with the drugs forever, and they can't afford them. And most of these, especially anticonvulsants and epilepsy medication, are very expensive. What is SHA doing to expand the essential benefits package to fully cover therapies, especially physiotherapy, occupational therapy, speech therapy, orthopedic therapy, assistive devices, and lifelong neurological medications? Thank you.
Odipo Kwame.
Thank you, Mr. Speaker. I think I have to congratulate our CS. His explanation was quite satisfactory. My first question to CS.
There's no first question, it's only one.
Okay.
So just ask one question.
It is one. Now, the lowest contributors in terms of payment do claim that when they go for treatment, they are told they must top up their contribution to cover a full year before they are attended to. I wanted you to tell me if this is what is expected. And do they, or do you cover all kind of treatments? And in particular, I wanted to know whether X-ray is covered, because they also say when it comes to X-ray, they have to pay for that outside the SHA system. And you mentioned something, Minister, regarding the medicine, which many hospitals, especially the county hospitals, they do not provide medicine. The problem you have there, you have explained very well, and your intention and what you do. But my concern is, what is happening to these patients if they don't get medicine? Do we just say bad luck, or is there any provision that they can follow to get the medicine they require? Thank you, Mr. Speaker.
Elachi.
Thank you, Mr. Speaker. I also want to thank the CS, to thank his team, Mercy and the team. CS, I was in Kenyatta on Sunday, and I want to thank you and thank Lesiampe. They have done their best, but I realized that because Mbagathi is not functioning and Mama Lucy, you find that we have 100 mothers now delivering a day at Kenyatta. And so my biggest worry now, which is across the country, is how do we ensure to have accountability? First of all, we ensure that newborns are also covered with SHA. Because you cover the mothers, yes, but the newborns, the postnatal, is something we need to look at as also going through and trying to push the hospitals to ensure stillbirth and newborn deaths are really recorded so that we know. And so for me, my proposal will be, in terms of just Kenyatta, is it possible to talk to the president so that these social corporate programs we do under affordable housing, they can just go and do some repairs in terms of their ceilings, in terms of their cupboards, and many other places that I felt it's really struggling. Thank you.
We have done those 11. Minister, because these are very short questions, let's take another 10 so that we answer all of them. This side.
Thank you.
Hold. Rachel, hold. The CS prefers that he runs through these ones very quickly before we take. Tutaanza na wewe Osoro, so don't grumble. And this side, don't raise your hands. Rachel said she'll deal with the sender first. Then we'll come to you.
Thank you, Mr. Speaker. You know, since I left Parliament and this difficult job, I'm aging. So I didn't want my memory. Honorable Speaker, first I want to thank members for the good comments, and I share that with my colleagues, those who are present and those who are not here, because we work as a team. So it is me and all my whole team that, you know, that even there's even somebody who is sitting here making sure that the slides move. It's part of the team. So thank you very much. Honorable Wangari, there's some questions I'll give to the DG briefly and Mercy. Particularly, Honorable Wangari's question, that because of monetary value, because C-section is complicated first, it's a surgery, it's a theater, it's 30,000 reimbursement, but normal delivery is 10. And because of greed, it's a social problem. Somebody wants to force a mother to a C-section when she can do normal delivery. But because he's looking at the difference of the 20,000. So even though we are developing something called scope of practice, I want the DG, and Mercy, she's the doctor, and DG to tell us what do we do, what do we need from Parliament to enforce that we stay within the range of the 10 to 15% of WHO.
Isn't it also an ethical issue?
No, it is, but I think we can do something. The system, Honorable. Two, I think also, I agree with you. Just like the wider society, we have doctors who go to theater when they're drunk. And that's why we are going to pick with the regulator to make sure that we enforce discipline. And I think the system now talks to Kenyans, so Kenyans must help us identify quirks in discipline. You know, patients must also be talking to us.